Hello, my name is Dr. Michael B. Sisti. I'm speaking to you from my office at the Neurological Institute of New York, Columbia University Irving Medical Center, New York Presbyterian Hospital. I'd like to talk to you today a little bit about a disease that I have a lot of experience with and my institution does here called Meningioma. If you or any one of your loved ones, friends or family member have recently gotten this diagnosis, I thought it might be very helpful, given the experience I have and the institution where I work, to kind of step you through preliminarily about what my thinking concerning this condition is and what are your options for treatment. So first off, let's just decode the word a little bit. If you have a neurological problem, such as difficulty with your speech, movement, memory, vision, or maybe just nothing at all, maybe you got a scan for another reason, you had a bump on the head, you had sinusitis or neck pain, and you have either a CT scan or an MRI scan of your brain, and one of your doctors who orders the scan, which is generally heroic in my opinion to get these scans because it's actually difficult to make this diagnosis because the tumor is so slow growing and benign, and your doctor tells you they found a growth on your scan. They're telling you the growth is probably benign, has been there for a long time, and it's called a meningioma. Of course, it's natural to be panic-stricken over this, but I'd like to give you some information, at least to calm you down a little bit and understand the terminology and the options to let you know that this is a condition that we can treat and we can treat successfully and that you're going to be okay. So let's talk about the word. You know, doctors use words for everything and many of them sound complicated or foreign to most patients who are not involved in the medical field. But I'm telling you, everybody who gets this diagnosis has heard this word before in a different context. Everybody's heard the word meningitis, and usually hear it with children or people who are in school. You get an infection with a really bad fever, a stiff neck and a headache, and you wind up in an emergency room, you get a spinal tap, you get antibiotics, and generally if it's bacterial you usually make a pretty good recovery. The meninges are the connective tissues that surround the surface of the brain and the spinal cord. These connective tissues, which are 3 layers, are not made of brain cells. You can think of it like envelopes that surround the brain that protect the soft surface of the brain from the hard inner side of the skull. It has other functions too besides protection. Your brain actually floats in salt water inside your head, and so these membranes keep the salt water in its place. And so if you have an inflammation of the meninges, it's plural, the word, because there are 3 layers, then we add the ITS ending and you've got meningitis. Okay. The meninges, because they're connective tissue, can grow tumors. Fortunately, these tumors are almost always benign or nearly benign. And so doctors add the ending OMA to the word meninges, and that's how you come up with the word meningioma. In my practice here at the medical center for over 30 years, it's actually a good word because generally if I get a call or somebody sends me a scan or an email or a fax or reaches out to us on our EMR system, and I always breathe a sigh of relief when I see the word meningioma, because to me, in general, it means a benign and always benign tumor that's probably been there for a long time. These tumors on average grow about 1/8 of an inch a year. And so that's good, but also it's what's treacherous about them, because a slow growing tumor that's coming from the outside and pressing on the surface of your brain's very soft and it will just gradually move out of the way. And in some areas of the brain that don't have critical functions, these tumors can have tremendous size, inches in size, before they cause serious symptoms, let's say with your personality or memory. Many of my patients look at the scans that you don't need to know anything about radiology to see them. They're very obvious. And they say, Dr. Sisti, it's just impossible that could be my scan. There's no way I could be walking around with something in my head that big. And I say, well, that's the paradox that's good for you. It's something that's very large and that's been there for a long time, and you don't have a lot of neurological symptoms. It almost always means your outcome's going to be really good. It's because the lesion is biologically benign. It's slow growing, and that gives us a lot of options. It's usually not an emergency in general to treat patients with meningiomas unless the location is critical, and so we have some time to slow everything down, take our pulse, take a deep breath, go over the options, get some other opinions, and get you comfortable as a patient and a family to know that you're making the right choice about what kind of treatment your doctor is advising to you. Now, meningiomas, because they're very slow growing, there are 2 types in general. There's a typical type, which is really slow growing, and then an atypical type, which grows a little bit faster and can be a little bit more dangerous. And the 2 types blend together a little bit. But in general, I consider these among the most benign tumors that I treat, and they have the best outcome. Now, shockingly, the risk factor is generally age. The longer you live, the greater chance you have of getting one. They're generally slightly more common in women than men. Let's not take this too seriously in some ways, because animals get them too. Dogs that have seizures, elderly dogs, they frequently have meningiomas. So it's not unique to our species. It's a common condition of the aging of the coverings of your brain. And studies done in the past show that many people are walking around with one or more of these and have absolutely no symptoms and will live a normal, complete life without any neurological problems and will never require any treatment for their meningioma, depending upon the size, location, the age, and what symptoms got you to that MRI scan. So the vast majority of patients who have meningiomas don't even know they have them. The patients we can talk about are the patients, of course, that have had either CT scan of the head or an MRI scan of the head, the two classic imaging tests that will show meningiomas. MRIs with contrast, we can see tic-tac size meningiomas. So imagine, you probably know people who have them who don't even have them because they haven't had an MRI scan. So many people who have a meningioma, particularly those that are found incidentally, which we kind of cutely call incidentalomas, almost always that's the kind of tumor that I'm going to reassure a patient. We'll look at the scans. If the location is not critical, and by that I mean usually locations over the surface of your head, I'm going to say, look, if you've got a small tumor and you have no symptoms and we know it's really slow growing, then we're making a prediction about your future by saying that. We can actually do the Ronald Reagan trust but verify thing. We can actually say, if I think you have a meningioma and it's small and we can just watch it, which is called active surveillance, I'm actually making a testable prediction about your future. And we can do a scan in 6 months. That's a check on the tumor, in my opinion, and that's the trust but verify thing. So if you have a small tumor and it was incidentally discovered, which is actually the most common situation, it's more than half my patients, I'm going to do my best to reassure you that you're going to be perfectly okay, that the two traditional treatments, surgery and radiosurgery, are probably not indicated for you. Because the tumors are so benign and slow growing, there really isn't a medical option. Like, there's no approved medication to treat a meningioma. They're so benign and they're so slow growing, medication really wouldn't work to any degree. So generally the options for patients, depending upon your age, the size of your tumor, symptoms and location, and maybe a little bit your personality too, because just because I say it's going to be okay, I can understand when you're sitting on the other side of my desk. That's a hard thing to believe. You know, it's an anxiety-provoking event. Most patients, they're so scared, and why wouldn't you be? Many patients have never talked to a neurosurgeon. Just the whole idea of it, famous quote is really, about the kind of work I do. Nobody wants to really be my patient. I hear this from my family members all the time, and I understand why, because I only do tumors of the brain of various kinds, and if you're talking to a neurosurgeon and you've never met or talked to one before, and you're reading a lot of things online, part of my job is to be a good doctor and to walk you off the edge of the cliff almost always and tell you that things are going to be okay. And at least for the patients that I see here at New York at the Neurological Institute, most patients are, I'm just going to put under active surveillance. So a classic situation would be you have neck pain and somebody does an MRI scan to check out your neck pain. And on your MRI scan, we do see your brain. And sometimes someone will come out to you and say, we saw something on your scan, we're going to want to give you some contrast. And next thing you know, somebody tells you you have a brain tumor. Okay, that's when you hit the panic button, but don't worry. I know you'll probably read it on Google, Dr. Google as I call it. You'll get at least some basic familiarity with the concepts. Our website and other people's websites are extremely informative about this, and if you go to any major institutions, Columbia's or other ones similar to it, you're going to get a lot of interesting information and learn some new words, most of which to a person like me mean a good outcome for you. So if you have a meningioma that's in a non-critical location and not causing you any symptoms, and you're older and have other medical problems, almost certainly, at least in my experience, it's better off for you that, at least in the beginning, we use active surveillance, an MRI scan. We see if the tumor grows, if you have symptoms. Because meningiomas can't spread in your brain and they can't leave your brain to go to any other part of your body, there's really not any crisis in terms of time to make a decision about treatment, particularly if you have virtually no symptoms. So we can use an MRI scan and a calendar to find out whether or not you really need the intervention. The intervention would either be surgery or non-surgical technique, which I do, called radiosurgery. So surgery I'm generally resolving for patients with tumors an inch or more in size, particularly if it's in an important location, like where you move or where you speak. I'm talking about meningiomas over the surface of the brain, in which you have a symptom. And so a larger tumor that's symptomatic in an important area, let's say a movement area. Let's say the left side of your brain controls the right side of your body. So let's say you're having weakness on the right side of your body. Maybe your doctor thought you had a mini stroke or had a stroke, and that would be a more common diagnosis, of course. And then instead, when they do your scan, they find out, no, it's not a stroke. You have a meningioma that's pressing on your brain in some way, that's irritating the brain, and has caused a neurological problem, occasionally even a seizure, which is a loss of consciousness or involuntary movement of some part of your body. And that's why you got the scan. Well, a symptomatic moderate or large-sized meningioma is one that we're not going to recommend observation for, and probably not going to recommend the non-surgical treatment for, which I'll go over in a little bit. We're probably going to want to do surgery on that. The ones on the surface, a lot of advantages, because the brain, which feels everything, doesn't feel itself, and many of you may have had colonoscopies or other kinds of dental procedures where you get the sedation through a vein and you don't remember anything, you don't feel anything. Most of my meningioma surgeries I'm doing with conscious sedation. It avoids the risk of general anesthesia. We could actually examine you if we had to, although that's not often necessary. And what I love about that is it reduces the risk of anesthesia. You don't feel like you had surgery. We can get you out of bed after the operation. You only spend a couple of days in the hospital. And one of my quirks is I really essentially never shave any hair in neurosurgery, so generally no one can ever see that you had the procedure done. And unless there's muscles involved, like on the side of your head or the back of your head, these procedures don't really hurt very much. So if you have a meningioma and it's caused a neurological problem, it wasn't incidentally discovered, then maybe if it's in a favorable location over the surface of your head, you know, conscious sedation procedure guided by computer right on the surface. You know, for neurosurgeons, things closer to the surface are much easier for us to get to, means more safer and better outcomes for you than things that are deep within the center of the brain itself. So, and those are really the majority of the tumors that I'm operating on. I would say about 60% are large meningiomas that are symptomatic, that cover the surface of the brain, and these patients, my patients usually do, if you come to me in good shape, it's really unlikely you'd even need physical therapy rehab. Generally you can come in, have your surgery, go home in a couple of days. Look, nothing about it's going to be easy. I can't take the anxiety out of it. That would be unnatural, I think, but I do my best to reassure patients that, look, we're there for you, and of course, it's not just me. I'm blessed with having some of the most talented people on my team that you could ever imagine. Everyone from the neuroanesthesiologists who are experts at conscious sedation anesthesia to the nurses I work with in the OR, the world-class residents we have here, the nurses on our floor, our neuro ICU, and our recovery room, even the person who cleans the floor of your room, serves you your food. I want to say that this is a very special place that attracts a certain kind of person at every level, from the top to the bottom in the entire institution. They want to be at a place where there's world-class doctors and difficult, challenging problems to deal with. It attracts a certain kind of person that loves the intensity and drama of this environment. And all of my patients are always commenting on me that everyone they run into, doesn't matter who that person is somebody special. And one of the reasons why I spent my entire career through medical school, residency, and being an attending here is because I've been surrounded by the best of all possible people, always make me look good and make my patients feel better. And it's been such a privilege to work with this group of people over the course of my career. However, sometimes a benign tumor in the wrong place can cause a lot of problems. And my real surgical specialty, my interest, things that I've published on and done non-surgical work as well as surgical work on, have principally been involved in meningiomas that are underneath the brain. Now here, size is a variable, but not always. So I have a particular interest in meningiomas that involve the base of the brain, particularly those that are wrapped up with the optic nerves, the nerve of hearing, smiling, swallowing, the junction between your brain and your spinal cord. These kinds of meningiomas, even though they're benign, they can really cause a lot of serious neurological problems, such as double vision, loss of vision, numbness or pain in your face. The nerve where you feel your face goes to your teeth and your eye. I've had many patients that have had large meningiomas, which you cannot diagnose easily from a physical exam or a blood test, have teeth removed, for instance, or patients were treated for their eye problems and it really wasn't a problem with the eye. Ophthalmologists can't really see these problems by looking at your eye, but many of them can figure out that if their treatments don't work, that maybe the problem is not in your eye or in your face or in your teeth. Maybe it's the nerves that are leaving your brain that are going to your eye or your face or your teeth or your tongue or your shoulder or your arms or your legs. And so these skull-based meningiomas are, of course, much more challenging based on size and location than meningiomas over the surface because they're wrapped up with the major nerves, of which there are 12 in each side, number 1 being the sense of smell, and number 12, the 12th nerve being to your tongue. Plus, of course, the blood supply to your brain, which comes from your heart, also enters through the bottom of your brain, and frequently these meningiomas, as benign as they are, wrap around both the large and the small blood vessels, and everybody's very afraid, including your medical team, about injury to these blood vessels, but you know, it's really not the big blood vessels we're worried about, it's the tiny little ones that supply the tumor or go through the tumor when the base of your skull is involved. So these kinds of meningiomas, patients with these difficult, very challenging ones, tend to wind up in major medical institutions like Columbia and NYP, where not only your doctor, but other doctors that you work with who have expertise in the blood vessels or the non-surgical treatment or even medical therapy on an experimental basis for these complicated meningiomas are involved. And so my particular interest has been meningiomas, particularly involving the eye, the optic nerve, the nerves of hearing and balance, and the junction between the brain and the spinal cord. And so some of these meningiomas, of course, are asymptomatic. So you may have a meningioma in a scarily location, but if your vision is fine, you don't have double vision or droopy eyelid or facial pain or hearing loss or facial weakness or problems with your swallowing, then you know sometimes your scan may be very impressive, but maybe you don't look so bad. And my teacher, my professor of neurosurgery used to always say to me, you know, Dr. Sisti, Michael, you know, better to have a good-looking patient than a good-looking MRI scan. He had a funny way of saying, we don't do plastic surgery on MRI scans. I think that's a really good point, because of all patients who have meningiomas, particularly those in critical locations, we're trying to balance the slow, benign growth rate of these tumors and the risks to your quality of life, your vision, your hearing, your smiling, your facial sensation, your swallowing. We're trying to balance those risks against the risk of the tumor trying to hurt you. We call that the risk-benefit ratio. So sometimes even a scary meningioma underneath your brain that has very few symptoms, we might elect to monitor that, or if it's about less than an inch in size, my surgical practice effectively is really large, symptomatic, challenging tumors, but the moderate sized ones, you know, we can treat those without surgery. And so because of my background, my educational background, I studied engineering before I went to medical schools. It was kind of a quirky thing in the 1970s. Not a lot of people were doing that, but when I got here, I had a very good background in mathematics and science and computers, and very early in my career, in fact, that's how I got my job here originally from that kind of background, was to implement computer-guided techniques, which are now, of course, completely routine. Everybody does them. But we got a real head start on this in Columbia in the 1980s, and here in New York, we actually hand-built at that time. You could do those things in those days. The first system to use a linear accelerator to treat what we consider to be difficult to operate or challenging to operate meningiomas involving the skull base. We started doing these in 1989. We changed over to the Gamma Knife platform, which is a more commercial and well-supported technological device to give very small, high-precision doses of radiation to tumors like these. It's highly effective in places where we don't want to operate. And over the period of that time, we've done thousands of outpatient meningioma surgeries. And so a small to moderate-sized tumor that's not causing a lot of trouble, that we want to avoid open surgery with, we have excellent non-surgical option. I'm a big advocate of this, particularly for meningiomas that are behind the eye in this place called the cavernous sinus that contains the nerves that go to your face, that almost everyone, when we tried to do these surgeries in the 20th century, came out with serious neurological problems with the eye, whereas radiosurgery is, at least in my personal experience, has pretty much solved those problems. And radiosurgery, it's usually done in one, but it can be done up to 5 individual sessions. It's an outpatient treatment. It doesn't require preoperative testing. There's no hair loss usually. There's no medications we give for it. With the new system that we have here, the ICON system, which we've published on, it's the 5th generation of Gamma Knife. I let people get on the subway and go back to work after these treatments, or they can drive back and forth. I've even had patients fly out the same day of their treatment. So it's interesting that depending upon the size of your meningioma, its location, your symptoms, your age, we may elect to monitor your meningioma. We may elect to treat it without surgery, which of course everybody would naturally prefer, as well as would we. Or sometimes you're going to have to find out what a good surgeon I am. But if you do your own radiosurgery, which I and my colleagues here at Columbia do, we don't really have a conflict about whether it's surgery or radio. It's about getting a good outcome with the least amount of risk for our patients. Sometimes you have to have the surgery because you're suffering from neurological problems or the tumor is just too big for radiation, then we could take out the majority of the tumor, 90, 95%, and maybe the parts that we shouldn't touch that are involving critical structures. Those structures, it's safe to radiate through them with a Gamma Knife. And so maybe we let you recover from the surgery, and if need be, 3, 6 months or a year after your surgery, those little pieces we leave behind that we're leaving behind for the quality of your life, what we call nerve preservation surgery or brain preservation surgery. If we get it small enough, then we can treat it without an operation. So sometimes we use this hybrid approach. If you have a large tumor that's symptomatic in a challenging location under your brain, then we do the surgically accessible part. If anything looks like it's not a good idea to take it out, the computers that we use to monitor you in surgery say, hey, Dr. Sisti, don't touch that. You know, maybe the person will have a problem that won't recover after surgery with time or rehab. Then maybe we should leave a little piece of your slow-growing, benign, non-cancerous tumor behind, and we could either watch it or treat it non-surgically with the Gamma Knife. I think most people who look into the Gamma Knife wonder where the knife is. The machine was commercially named for your doctor, not for the patient's no knife in it. Remarkably, these treatments were done on an experimental basis in Sweden in the 1960s. The first machine was sold in 1984. That's before even we had MRI scans. And the current evolution of radiosurgery is now the ICON system. And I have one of the ICON masks here. It looks a little intimidating, but I love this thing because as opposed to putting your head in a frame that would pin on in the front and the back with small titanium pins in 4 locations, we can make this warm moldable mask that holds you perfectly still and allows the machine to know where your tumor is, and it designs a single custom beam of radiation for you, and it puts it on that place with incredibly high precision. You don't feel anything, you don't hear anything, you don't see anything. And then we take the mask off. I usually give it to my patients, and we let you go about your life that day. I mean, I've had patients get on the A train here in New York. Our Gamma Knife's on Broadway. There's an 8th subway stop out there, and I have no problem with people using public transportation or driving after these treatments. If you could come to me by subway, you can certainly leave after the treatment by subway. So sometimes we have to do a little bit of both. Sometimes you need a little bit of surgery, and sometimes you need a little bit of radiosurgery. Sometimes you don't need anything. So I think, you know, when you're looking into the options for treating this, it's always good when you get over the shock of you're going to have to see a neurosurgeon. You know, you should get a couple of opinions, somebody like me or somebody with my level of experience, you know, in a place where they do a lot of these, and most importantly, where they've not only your surgeon, but the people who the surgeon works with, the anesthesiologists, the nurses, the residents, the rehab people. You know, many of these tumors in exotic locations are actually fairly rare, and you want to be in a place where everybody thinks that what you have is a routine problem that we see every single week. Not just me, but everybody that helps me to get a good result for you. And so if you come to a place like this that has these kinds of resources, then your anxiety level goes down quite a bit. You'll see right away that everybody is really on your side and can explain things clearly to you. It's so complicated, but people have a really nice way here of making complex things clear for our patients and at every level, and to support you whatever you have to go through to get back to good health. And so I think when you have surgeons like myself and my colleagues who have 2 kind of career tracks here, one as advanced intraoperative micro neurosurgery and another one non-surgical options, maybe you get the best of both worlds. You don't have to see that there's a conflict. I really see that these technologies are complementary. They don't really compete against one another. There is no competition here between surgery and radiosurgery. The idea here is a good result for you and your family members, and however we can get that, whether we should leave you alone, whether we should operate on you or radiate you, or a little bit of both, however we can figure it to get the best result with the least amount of risk for you, I think that's the way we're going to go. Now, what's going to drive you and your family members to distraction and drives us to distraction, we understand this intuitively as doctors, is that because of the rarity of these conditions and the differences, there isn't a defined, absolute way that every good doctor would do this. And, you know, of course, I'm here in New York, and there are many good surgeons here in New York, in my department and other departments, and my patients are baffled by the fact that, hey, good Dr. A said X, and good Dr. B said Y, and good Dr. C said Z. I mean, how is it possible Dr. Sisti thinks you don't need anything, and another doctor thinks you need surgery, or Dr. Sisti thinks you need radiosurgery, or another doctor thinks you need operation? You know, it's because for a doctor to have an absolute answer about the best way to treat you, we'd have to do a randomized trial. We'd have to have a lot of patients just like you. We'd have to separate some to watching, some to operating, some to radiating. We have to follow patients, because it's not a life-threatening condition, for at least 10 years. And then we'd have to agree that that study was so well done, that one way of doing it was so good that everybody would agree that's the way to go. Unfortunately, because of the relative rarity and differences, and try and run a clinical trial like this, I don't think it's going to happen in my lifetime to any degree that anybody with my level of experience is going to agree there's one right way to do it. And so I explain this to my patients in the office consultation to say, hey, look, you know, your well-meaning, experienced doctor has a certain style of practice, and that style of practice works for that doctor based upon where they were trained, what their experience is, what their publications say, you know, and how they relate to patients. And I think you as a patient have to realize that if we, among ourselves, experts, can't come up with an absolute clear answer about a black and white decision for your tumor, you have to use a little bit of your instincts. My teachers taught me here that, look, neurosurgery is extremely complicated even for people who do it. I mean, how do patients make decisions when the information's incomplete? Well, trust me, you've been making these decisions your whole life. The clothes you wear, the food you eat, the car you drive, the person who you married, the job you do. I mean, I'm sure all of you had a lot of choices in life, and for some reason or another, you got to a certain place in your life through certain choices. So, you know, the brain actually, it's not happy about it, creates anxiety and fear, but your brain is always making decisions with imperfect information. And so I always tell my patients, you know, among good doctors, this is surgery, radiosurgery, observation. This is style, not substance, for many doctors, and for patients too. And I think doctors, at least myself, you know, I have a certain way of doing things, and I think they've worked really well over the long period of time that I'm doing them. I've had the chance to publish long-term results, particularly in meningiomas involving the base of the brain, the most complicated kind. All of these publications are available in the major neurosurgery journals. We always make them so I feel sorry for you, you have to want to read them, but you could. They're all available free online. They cover some hundreds of patients, including radiosurgery and surgery. And so we made an attempt here. It's not a randomized trial, but we've made an attempt here in our own experience to validate our approach to patient about the type of surgery, the conditions for surgery, the conditions for radiation, how the two things collaborate together for the most challenging problems in neurosurgery. And we kind of stick to those ideas. There's some flexibility, but I understand that other doctors who are really good want to do it another way, and that's okay. I can't say that that way is wrong, but it's up to you, the person, to decide what makes the most sense to you. And I know it's gut-wrenching. You know, it happens to me when I see my doctors and they don't have exact answers for me. I feel the same thing you feel, but at some point, you know, you're going to know you're making the right decision, and whatever my patients decide, I support their decisions 100%. And it's because, shockingly, patients make really good decisions, even if you don't really know a lot about these complicated things we're talking about. And I think there's something in human nature that helps a person to make a good decision. So I guess I'm trying to say, you know, trust yourself a little bit. I know you're scared. I know this is really intimidating, and nobody wants this really, but you have a meningioma, you're going to be okay, and we're going to be able to manage it, and we have great options for you. So if you have any questions, you can call our office, reach out to me on our website, and we'll be happy to see you in person, see you on our video system, telemedicine. I think particularly for international patients, I'm generally saying, if you're in Brazil or you're in Europe or you're in Southeast Asia, hey, before you get on a plane and come to see me, maybe you don't need to see me. Maybe we can just do this all remotely and save you enormous aggravation and expense for me to just tell you that you're okay and you need a scan in 6 months or something like that. So particularly if you're looking here in the North America, Europe or Asia, Latin America, we have great international services here. I have many international patients. Maybe you don't need to come and see me, and we can save you a lot of aggravation and expense. We can just do this remotely. It's really easy. And so I'm generally saying patients, it's really hard to get here. You'd be surprised, here in Manhattan, if you're coming from Brooklyn to northern Manhattan, that's a big deal. And sometimes my patients from Brooklyn prefer to do this remotely as well. I get it, traffic here is difficult. So if it's a problem for you getting here to us, because we're a medical destination, then don't worry, we'll do this remotely by telemedicine. And maybe you don't need to come and see me in person. We have many ways of dealing with it to make it easy as we can for you, because we know you're stressed. Okay, I hope that answers some of your questions, and feel free to reach out to me in my office. Everybody here is great, and I'm sure we can help you.